Welcome to the Sense of Hope podcast with One Life. I'm your host, Helen Diveston, and today we are speaking to Rachael Sumner. Rachael is a senior research fellow at the University of Auckland School of Pharmacy. Her expertise is in using brain recording and blood analysis techniques to understand chemical changes in the brain. She has worked with LSD, ketamine, and scopolamine in the context of developing novel treatments for depression, and is excited by the potential for microdosing psychedelics in this space. Rachael has a particular passion for women's health and menstrual cycle-related disorders. Just a reminder that today's podcast is about using psychedelics as a form of treatment for mental health issues, primarily depression. I want to remind you that this is not to be taken as medical advice. This is purely about research that's been done at the University of Auckland. So please take that into account when you're listening to this podcast today. Rachael, how did you get into doing the work that you're doing? Because I understand that you started in psychology, is that correct?
Yes, so I went to university thinking that I was going to do marketing, and that psychology seemed like a good degree to do as well. I fell in love with the brain, and my journey ever since has been towards increasing the neuroscience component of my research. So I got into this research by taking cognitive neuroscience principles and applying them to how we can study how chemical systems change in the brain. And ultimately, what brings me here is how doing that can help us develop new treatments for depression and understand why drugs like psychedelics might be really promising for mental health.
I'm really fascinated as to how you got into the psychedelic side of things, because I know for me, I've been a nurse, I've been in psychiatry, and the initial thought of using psychedelics in treatment just seemed completely far out. And it was something, and initially I was like, what are they thinking? Now, of course, my mind has been changed, but how did that happen to you?
I think I'm slightly different to the average psychedelics field researcher because I came into it, probably similar to you. I knew very little about psychedelics. It just wasn't a part of my life, really, and it wasn't a part of my science until I was doing my PhD with ketamine, which is, it's controversial to call it a psychedelic, but there were these profound psychoactive experiences. And Suresh, Dr. Suresh Muthukumaraswamy, Associate Professor at the School of Pharmacy, was my PhD supervisor, and he is passionate about psychedelics. He had 10 years of research experience in psychedelics from sort of ketamine and through the research on LSD. I suppose he taught me about their potential. I am so interested in any drugs that provide hope for new treatments for depression. I'm interested in measuring plasticity and how changing plasticity could improve depression. Psychedelics do that. So my passion, I guess, is a mix of teachings from Suresh, a journey through ketamine, and matching how psychedelics work with the potential for new treatments, bring those together, and that's why I'm here.
So what has been studied, or what is being studied currently at Auckland University?
So we have a variety of projects. I'm involved in the LSD work mostly, and that is how LSD, when microdosed, could be effective for depression. But there are other awesome studies going on, some with LSD microdosing, but in end-of-life anxiety and those sorts of things. There has been research with DMT in the past. There's still ongoing research with ketamine. There is a study using MDMA. And these studies are more, actually this ketamine and MDMA study are more in the psychotherapy space. I have very little to do with either of them. The other study is a really exciting one that I do work very closely to some of the people on it, and they're investigating psilocybin as a potential treatment for addiction. And this is a Māori-led study that will take place on the marae, and I think that's so exciting.
That is amazing, isn't it? I have heard of that study. So having it marae based And when I've heard about the treatment using psilocybin, so for those listeners, it's magic mushrooms is probably the layperson's term for this. I've heard that it's very important to have the set and setting correct. Now, is that why the Marai basis is used? Obviously, if it's a very clinical setting, that might impact the experience of the user. Is that correct? Do you guys take that into account?
Yes, that is correct. And I think that's a major part of why this is being completed on a marae, because it's to address a major concern for Māori communities. We know that addiction is disproportionately represented there, and that treatments really have to be with the community and for the community. And when your community, your safe space, your culture, your intrinsic, your whakapapa, your being is on the marae, then from those principles of set and setting, which we know are so important for psychedelics, then that is the place to start. And that, yes, the clinical, the drugs still work in clinical settings, but maybe they can work better, or people can journey through them better, especially those macrodosing experiences.
I think it sounds amazing. And so if it's on the marae, are the kaumatuas involved in being the guides, or how does that work?
Oh, so you'd have to, and you should, if you can, speak to some of the wonderful researchers, because, like I said, I work near them, and I'm just hearing, things.
Oh, you hear the snippets.
I hear the snippets. I've actually got quite big FOMO for this study. I just really enjoy hearing about it, but they do have the kaumātua involved.
Right.
It's very much Māori led. And it's very much that us at the university offer more the guidance on the must-dos of clinical research, because, as you know, it's an administrative process, it's a governance process, it's a legislative process.
Yeah,
it's a ethical process. Like, we have guidelines and things like that, and that's where we can help. But my understanding outside of that, it is kaumātua, it is the people,
Very cool. So I've listened to you name a few of these medicines, and I only recognised one as being legally prescribable in New Zealand. How on earth what are the issues around using these drugs, for want of another word, these treatments that clearly are not legislated in New Zealand? What are the hoops you need to jump through to use these?
It is a probably fairly unimaginable amount of paperwork. And it's an amount of paperwork that you wouldn't know until you were sort of halfway through it, because it just emerges in front of you. That's been my experience. Suresh has been the person navigating it ahead of me. So it's at the point where you try to get approval to use these drugs that you really notice their sort of scheduled status. Because everything from where we store it, where the safe is,
Right.
all the way through to approvals to MedSafe, to get ministerial approval, to get HDEC approval, which is the ethics committee. Those things are a massive amount of work. And then on top of that, we're also talking about a drug that is not in a prescribable format, for want of a better term. So we have to get drugs that are GMP, that's the word I'm looking for. So they have to be of the quality that you would expect when you get your prescription from the pharmacy. And that's for all drugs that you give in a clinical trial format. So there's also all of that paperwork, but then you also have to think that then, because it's of the drug, all the sites where that gets created all have to have the right storage, the right procedures. So just, I would say it takes about 2 years from let's do the study to giving the person the drug, or it has done so far. Hopefully that gets shorter with our experience, but 2 years of administrative work is what it takes to get one of these studies to go. And it would not take that long if it wasn't Class A or Schedule 1.
My goodness. Okay. So a hell of a lot of work by the sounds of things.
The other challenge I found is also you might find, like our first study, for example, was in very healthy males. Um, and they all had to have certain types of occupation in order to be able to take the medicine. And we didn't include females to begin with. Navigating the space of the potential for pregnancy was, again, a massive administrative load. So we're getting more adventurous now as we've had more time and got further. But there are also like small other ways that you'll notice it impacts the way the science works. Yeah.
God. Yeah.
And so she's very passionate to have pursued that.
To push this through, absolutely, because I can understand it would be very easy to go, oh, it's just all too hard.
It would be. Yeah.
Yeah. So what have you studied?
I have mostly been involved in research in major depressive disorder. And I specify major depressive disorder because I'm interested in moving into other depression-related disorders. So I have been involved in, I mentioned the ketamine study. I class ketamine as a psychedelic because by definition it is. So that was the first. I'm assuming you're asking about what psychedelics they've studied.
Yeah.
So ketamine and then LSD, both in the context of the microdosing healthy young males taking home microdoses for 8 weeks and seeing if it changed cognition, personality, measures of sort of daily life, essentially to see whether all these claims that people make when they microdose in their own time were correct, and also that whether it was safe to do so. And because it was safe and it did show promise, what I'm involved in now is the LSD for major depressive disorder. So you see that theme of MDD research. Where we've just finished an open label trial, which means that everybody got LSD, and we were interested to see if it was safe, microdosing was feasible, and did it show any indication of shifting the needle on depression. And underway at the moment is the placebo-controlled randomized trial for that. So yeah, those are the studies I've been involved in. You mentioned in my introduction scopolamine as well. Scopolamine is not so much psychedelic, but it does have dissociative effects and can have hallucinogenic effects at very high doses. Not the doses we were giving, but that was also, we were interested in that as a rapid acting antidepressant for major depressive disorder. I personally tend to oversee the investigations into the potential mechanisms by which these drugs are working. So I'm interested in identifying shared mechanisms or diverging mechanisms, because that might tell us about which drug to try next. It might tell us about why this is a good potential drug, which is really important when you're trying to sort of change the current state of things, and you want to introduce a new drug as being potentially beneficial. So for that, I do brain recording with EEG, so that we can assess what's happening to the major neurochemical systems in the brain, how those are changing. And while we can't get an actual blood sample from the brain, we can tell a lot from what's happening down in the body. So I take blood samples as well, and we knit that information together to get an idea biologically what is changing, because we know what's changing is very different to the current sort of state of the art, state of medicine.
So do you have any stories, or what have you noticed? Like, what have people reported? What have you seen as part of the research and the improvements or the changes in people's mental states using these treatments?
So to speak to microdosing specifically, I think what was interesting is I went into it sort of actually expecting that it would do nothing, that it was just an elaborate placebo. Very low doses, and generally very low doses are, not what you do.
Right, the lay person,
therapeutic, concentration. Whatever. So, and plus at the time, there were some initial studies coming out saying they weren't really doing all that much from placebo. So what was remarkable, what we noticed in that first published study was that actually these drugs did do good things, even to very healthy people, but they tended to only happen outside of the lab, which is perhaps not exactly mind-blowing for the people that might have tried microdosing themselves, but it was a really important validator of us doing the research the way that we are. And then we obviously were able to give people with depression these microdoses and get them to take it home. And we have to admit that we didn't have a placebo control. So we don't know how much of that is drug related and how much of it is placebo. But we've noticed a really massive shift in the needle on their depression. And those results should come out relatively soon. And that's extremely exciting because I would say that it seems more than placebo. I'm a very skeptical person. I'm very ready to see these drugs sort of, if they don't work, I'll just move on to the next drug that has promise. But I'm looking at it thinking that's more than a placebo. That's got to be more than a placebo, because I've seen a lot of placebo responses in my time. They've got a predictable shape. And so that's exciting. Now, that's just saying that depression got a little bit better. But I think the behind the scenes part that I find really interesting is the qualitative interviews, which as somebody who's head deeper and deeper to neuroscience and like maths and measures and modeling, that's not something I expected to say. But it is the case that when you ask people a bunch of like scheduled questions, it's not the same as when you get people to just discuss their experiences, and psychedelics have their own unique effects. And the thing that just seems to come through when people microdose is the sense of kind of connectedness. Like people will talk about being able to get down on the ground with their children, engage more in things that they were interested in, or feel more connected in relationships, or feel more energy. And these are things that are not actually commonly associated with antidepressant treatments. They're not things that people expect to feel when they take antidepressant treatments. So I think that's extremely exciting. That these drugs consistently seem to produce these same types of effects, and my brain just becomes abuzz with the people who that could help.
It's so interesting, isn't it? Because if you look at the diagnosis of major depressive disorder and the DSM-5, I mean, it's very rigid and you must fit into these sorts of criteria. But there's no wiggle room. For example, do you feel connected with others, more connected with others? Whereas these small changes actually have a huge effect on a person's well-being.
Yeah, and they're quite practical changes. So, for example, one of the reasons why I've discovered it's so important to probe this, right, is that you might see a change on a domain that's in the DSM on one of the scales, and it says that I felt less anxious, for example, and that might only be two points down, and I was able to do things that I used to enjoy, and that might only be 2 points down. And those might be the only things that changed. And that would not come across on the MADRS, Montgomery Asperger Depression Rating Scale, as something that was clinically, significant, as a shift. And yet you talk to these people and they say that this was life-changing for them, that this was massive for them, that they would absolutely keep taking the drug, because behind those scores, as you said, are social experiences that they haven't previously had, feelings of things being more meaningfully connected. And then from that, you can expect a positive life might grow. So it might be that there are only 4 things on the MADRS changed on the day that people microdosed. But if you have positive life experiences for long enough, and you can grow positive relationships, then you can see how that might grow. But you can see how the usual way of assessing whether these drugs are working might really not capture the whole depth, because you're right, the scales often aren't. We're trying to find scales that do, but they're often not asking about the tiny ways that psychedelics improve life. In fact, if we think about the way current antidepressants work, the way that they work is they tend to remove negative parts of having depression. They don't tend to add on positive things of having a life. And that's very good. So you might find that you're less tearful, you're less irritable, you're less, you've got less negative self-talk and all that, and less extreme emotional changes. And that's all very good, but it does mean that the scales aren't in a position, because we've never been in this position, well, not since the 60s anyway, where we've tried to add on positive experiences as part of a depression treatment. And that's what we're seeing move. That's what I see move. And
That's
It's so
fascinating,
interesting.
isn't it? Yeah. Oh my God. I absolutely love this topic and so interested in it as well. And I mean, the experience I've seen a lot of people have, not all, but a lot of people who take antidepressants, is that
Mm,
yes, their negative emotions or their negative experience have reduced, but so have their positive experiences. They
yes.
kind of come
Yeah.
to this flat line.
Yeah.
Whereas it sounds like with these psychedelic therapies, I'm assuming you get the full range, but in a much more normal way. The depressive symptoms have reduced, and then you've got the positive symptoms of feeling good and, experiencing a whole full
Yeah.
life, really. And
Yes.
connection sounds like a huge part of that, which is that's super amazing. Do you have a favorite? Like, have you seen some results, or do you have like a favorite medicine that you've been involved in the research of?
So can I give you two answers with two different hats on?
Absolutely.
So my first answer of what my favorite was, if I just put on my pure major depressive disorder hat, is I just cannot get past ketamine as a psychedelic treatment. I I agree that the classic psychedelics, have so much promise, but ketamine is a safe drug that we already have in the toolkit. It's already sitting across at the hospitals, and just to see this drug developed, given it a quarter of the dose of what's required for anesthesia or whatever, just a small portion of the dose to lift people out of some of the most profound depression within hours. It's just, I really got this impression during my doctoral studies that it was such a special drug. It was such a special opportunity to shift the needle for people with depression. And I think that's what it has been for quite a lot of people, where it has become more available overseas and in Australia and the UK and the US. So I think the practically minded person in me that says we need new treatments now. We need treatments that are cheap. We need treatments that we already, that everybody can agree is safe. My favorite is that that's already in the toolkit. It's already there, and it works like this.
Mm.
So my favorite drug, and probably and probably where I said it was a life changing experience that put me on the path of being interested in psychedelics and things. So I can't. My major depressive disorder treatment hat, I think, is my favorite is ketamine. And as a scientist and as somebody with hope for the future, I'm excited about psychedelics, but my old favorite is an old drug. And then of course, I mean, at this point, I'm starting to sound like I'm not ranking a favorite. I'm just ranking the ones that I've researched.
That's all good. They all sound like they're doing a good job. So, yeah.
I think something that I'm excited about by the potential for sort of microdosing. And to be honest, I'm not that bothered whether it's LSD or psilocybin. I think they are probably relatively equally useful. We research LSD because it's the easiest one for us to do, and it's very effective. There are some advantages. Then psilocybin, same. It's just not the one we got our hands on. There are some advantages, some disadvantages. But anyway, I think the idea of microdosing. So my other hat that I wear is a women's health hat, and menstrual cycle related disorders and major hormone related disorders. And there's two reasons why I realized microdosing is a massive opportunity. Because you know how we talked about increased connectedness and improved relationships and all those sorts of things? Now, there's a specific type of depression where those are major features. And it's things like postnatal depression and premenstrual dysphoric disorder. And I sort of get this feeling that these drugs are kind of like singing out for women's health, mental health, addressing a cluster of symptoms where like bonding with family or feeling meaningful and a part of it, or a part of relationships, a part of the family, and all those sorts of things are such a big part. And maybe like overcoming and working with trauma, which is again a strength of psychedelics more generally. And And then, of course, I'm a giant neuro geek, but there's also this massive relationship between these specific disorders and serotonin and the way that these drugs work on the serotonin system. And so it's not even just a match between the idea of the drug and the disorder, but actually the chemicals of the disorder and the chemical systems that the drug affects are a good match. So my hopeful future and my women's health hat says that microdosing, because another thing is small doses sometimes are appropriate for somebody looking after a baby. You could be breastfeeding, right? And you could just store on the day that you microdose and breastfeed on the days that you don't. I'm not saying that's advice, but that is something that I'd love to investigate, because we haven't investigated it, let me be clear. But that potential that might work, that might actually, I don't know. You can see my brain is just going.
Yeah.
So Solve It Now Self says ketamine, like fight a future for better women's mental health, better mothers' mental health, better health for people with a menstrual cycle. Says microdosing psychedelics, there could be something so special in there.
Yeah. So I guess my next question, of course, is like, do we have any potential for these drugs to be legalized so they can at least be prescribed, like they can become prescribed drugs? Because I mean, obviously that's a huge block to being able to use these drugs for, you know, the average person that may be experiencing PMDD, for example.
It's something that I've said a few times to people. First of all, I mentioned how ketamine was my favorite drug and how it's so effective, and how I was doing research in 2015, 2016, and that I've seen it be effective in Australia, the US, and the UK. And that's quite directed. I never thought that such an amazing drug would be so difficult to get your hands on in New Zealand still, almost 10 years later. So before we even think about bringing these, Schedule 1 Class A drugs to the prescribable situation in New Zealand, we have to ask ourselves, what's our problem with ketamine? Because it's safe. The ketelar itself is effective. Other countries are doing it. The ketelar that's used in anesthesia and in paramedicine is cheap. So what is our problem? And my fear is that it's a problem with psychoactive drugs, and actually the resourcing in our mental health system to facilitate people taking psychoactive drugs, because to start with, it does have to be under supervision. And then we think about legalizing for New Zealand, and my heart sinks a little bit, because if we can't get our head around ketamine, where are we going to get our head around psychedelics? That's my fear. However, there is some reason for hope, is that if we do the clinical trials here, there is a pathway for quick prescribing and rapid access. Now, you'd have to go and talk to one of the people on our team that works more in the legislative side of things, because I don't know how that works. But I do know that that's a thing, that there is at least an advantage that we're doing the clinical trials here. Because if we do the clinical trials for the new medicines here, there's some legislative magic that means that we can get rapid access approval, and that does give me hope. But we're going to need better than that, right? We're going to need I want to be talking about how they've rolled out in 15 years' time the generic microdosing LSD, because it's just such a standard, safe medicine. That's what I want. Not some legislative advantage to doing research. And that bit, the prescribing, the generic drug coming out, that whole thing. I don't know if we can't get our head around ketamine.
Yeah, we're just going to start with the one first. And it's incredible, isn't it? Because, you know, from when I read Michael Pollan's How to Change Your Mind, which changed my mind about psychedelics, the research that they were doing in the 50s, 60s, and very early 70s was quite profound, was amazing. Yes. For all sorts, you know, cancer survivors, depression, PTSD. And I remember reading all this, just being blown away. And then it was just all shut down. It was just all shut down, and it all kind of went into hiding for 30 or so years. And slowly now it seems to be coming out and, hey, let's look at this again. Do we need to be doing the research slightly differently? Apparently got a bit loose back in the day, well.
Yes, the standards were different.
Different.
We have a lot of challenges to face. One of them is the concept of a double-blind randomized controlled trial. Microdosing, we get away with that a little bit, but we've really shone a light on this concept of functional unblinding. People know when they've taken a psychedelic versus saline, and there's really no way around that. And then the added challenge that any psychoactive drug that looks like a psychedelic tends to have an antidepressant property, so you can't come up with a active behavior match, something that feels the same and isn't therapeutic. So what if the gold standard is an RCT? How do you provide an evidence base for a treatment when it's impossible to conduct a gold standard RCT? There are some challenges.
Yeah. Do we still need to be doing actual RCTs? Like, is this appropriate for this sort of type of research? If we're quite clear that if someone has been given an active substance, and I think because when I was working for that small amount that I worked in the University of Auckland, I remember hearing or being part of a conversation, and the conversation was literally around, it was very, the assessors were not supposed to know who'd taken the active drug or the placebo, but it was so evidently clear when the person had had the active drug, because they came out different people almost with incredible
standing up straighter, faces brighter.
And you can't go, I know, I couldn't possibly tell which one he's had. So I mean, the blinded is in the researchers not knowing who's had what was just completely blown.
Yep. And then that is a challenging, it's something that in some ways the regulators aren't ready for. Definitely. So if you can't, then can you create an evidence base without RCTs if you know that the drug works? And there is harm and risk, right? So I guess what people might be afraid of is that if you give somebody a drug that is no better than placebo, right? But you give them the actual drug and it comes with risks and it comes with potential for harm. And they would have been fine if they just had a sugar pill. Then you're not only exposing them to risk, but you're also costing the economy. It's expensive to give people a drug that it was no better than a sugar pill. It's risky to give somebody a drug that was no better than a sugar pill. So they really do want an evidence base to say that this is better than giving people a sugar pill. And of course, people are going to be screaming out, well, yeah, of course, psychedelics are better than a sugar pill. But these are the rules. This is what we do. And there are massive placebo responses associated with psychedelics because they affect you so profoundly, because you know that you've taken something, because there's all this excitement around them. There's so much information on how they could benefit you around them. They're the ultimate placebo. They if you wanted to generate a placebo response, the hoo-ha that comes around a psychedelic is
tell someone they're going to get psychedelics.
And then set them up in these therapeutic environments and give them this special class A Schedule 1 drug, do all that stuff to get a whopping great placebo response, and then the associated media and feed into their expectancy. So it's a relevant concern. What the solution is, I don't know. I think one of the other interesting things that has come out of it is that there probably is quite a lot of functional unblinding happening all the time in every treatment. A lot of medicines they might not make you feel psychedelic, but they might make you feel awful, a lot more awful than saline would have. The surgery might give you a lot more pain than a fake procedure would have. I think the other thing this has shone a light on is that there's probably a lot more functional unblinding out there. So we're challenging the RCT not just for psychiatric research. I don't know if I've answered any questions. What do you do in the meantime if you don't
Yeah.
have an evidence base? Like what
Yeah.
do we do? Do we just abandon them and stop studying them? No, we keep studying them. But how do the regulators approve when their rules are such? Don't know yet. Do we keep studying until they work it out? Probably. What types of studies do we do? Good question. Like,
Oh man, it's huge, isn't it?
Yeah.
Yeah. So you did mention risks before.
Yes.
What are the potential risks, or what, have you seen any negative associations or negative consequences from people taking psychedelics?
So the negative effects and the risks are often not to do with the drug's intrinsic effects on the body. They are very safe drugs, but they put people in when they're not microdosed, they put people in a very vulnerable space. And that much is real. And it's why, for example, it's recommended that people have somebody with them, that they have a safe space, because it's what you might do while you're under the influence of psychedelics, and what the other people around you might do while you're taking psychedelics. Now, clinical trials are very safe generally, but there are all sorts of issues that have been in psychotherapy, for example, for years and years. They've always been a thing, because ultimately humans are delivering psychotherapy and humans are flawed. They're delivering therapy to other humans, and when you get a lot of euphoria, a lot of fear, a lot of vulnerability, a lot of loving feelings, a lot of things, risks happen because the therapist is at risk and the participant is at risk in a way that is standard within a therapeutic, clinical, or medical treatment environment. And so there are risks there, and compounded by the fact that we don't have a school of teaching of psychotherapy for psychedelics that is as regulated, as understood, as shared as we do with other therapy models. And so we don't have, the usual councils and regulators sort of overseeing the way people get trained, and the concepts of, countertransference, all these sorts of, usual patient think that the volume's turned up on when you've got psychedelics. Now, in the microdosing space, and maybe with macrodosing, there is one potential physical risk that it is important to investigate, and that's the potential for cardiac effects with long-term use. We have serotonin receptors all over our body. So if you give somebody a drug, and this is why you get often side effects from drugs, is because there's the target, the thing that you wanted fixed, and then there's all the other parts in the body that the drug also went that you didn't really need. And one of those is the heart. And so if you stimulate regularly the serotonin receptors in the heart, that psilocybin and LSD do stimulate, there's a risk that you will get heart problems later on. We don't know, actually, whether that is important for microdosing because of the dose.
Okay.
But we should gather evidence. So the FDA has recommended that we gather the evidence to see if it could be a risk. So yeah, we can't say yet. Yeah.
Interesting. Okay, so just this is a total side. You might not know the answer to this, but if we're talking about serotonin receptors and cardiac issues, is that also the case with antidepressants?
I think the reason why psychedelics bring it specifically, now antidepressants, I can't remember whether they would, because they increase circulating serotonin, but the issue with the psychedelics specifically is actually that they bind to a special type of the serotonin receptor that's in the heart. So they do it in a much more direct way.
Yeah.
And actually it's something that psilocybin does much more than LSD does. So different drugs have different risks. It's called the 5-HT2B receptor.
Okay.
Yeah.
All right.
So they do 2A, 2C, but they also do 2B. And 2B is the one that could cause heart damage. Don't know yet if microdosing would do it, but it's enough that we should follow it.
Yeah, absolutely. Okay. Are there any interesting stories that you've heard of people's recovery due to either maybe a clinical trial, or is there anything that you can share with us?
Oh, do you have, of course I have hundreds of stories. Do you, and usually I can, generalize things together enough. I would never expose any of my participants so that they could be recognized. But do you have any specific things that?
I'm wondering if someone has had a experience where they've perhaps come for a trial and they've, like you said, for example, their depression completely lifted, and what that experience was like for them, or how they then went on to live their lives. Or I do remember one story, and I think that was the one that they were talking about, and I won't give any details, but I do remember that person had experienced such a transformative experience during his dosing that, and I think it was ketamine actually, that it was a complete game changer.
Yeah, there's so the story that came immediately to my mind is one that we have published as well, actually, in one of our papers, so I know that it's okay to
Safe
talk
to
about.
talk about. Great.
Yeah. And that's because you can't identify the person from the story, but it is also probably a story that maybe a few people would be able to relate to. Is that when you've experienced depression for such a long time, the people who came into our ketamine study, they had, by definition, sort of moderately treatment-resistant depression. So they'd tried antidepressants and their depression hadn't shifted at all. And so they'd become sort of the view that their depression was fixed and that it couldn't change. And that, in fact, that it's just that they knew how bad the world really was. And the rest were just, naive, just didn't know. And so this kind of truth that they sat with was heavy, and it was an unmovable depression. And they tried ketamine in the context of the research study, and the profound way with which by the next day their depression had been almost grabbed out of their brain and put somewhere else, and that they didn't feel high, or it wasn't that sort of thing, but that they felt not depressed and good about the world, made them realize that it wasn't just that they had some ground truth, that it could be chemical, that it could be their brain kind of sabotaging them in a way that was fixed now. And then something that a lot of people can relate to is basically that not only is it just chemical in a way, but that it can move and that it can be made to feel better. And that meant that even though they were turned out to the world without ketamine, they weren't the same as they were when they came in the study. So I can't remember specifically, but a lot of people who were in this situation, their depression had relapsed by the time we weren't in contact with them anymore. These people who had this sensation that, oh, my depression can move, but they moved forward with hope to maybe try other treatments, because actually their belief that their depression was fixed as an unmovable, in a fixed position, was not true. And that's something that a single dose of something that can profoundly remove depression can do. And it was just so special, because it's one of those things that any therapist would try to try to yell from the top of the buildings. It's not you. It's not like this can't move. It's not that life can't be better. But how do you show somebody who is in such a hold that they can't see it for themselves, that they can't hear you? And then think of the opportunity that a therapist could have had in that moment to build on that person's feelings. I don't think I'll ever forget that.
That's amazing. And I can just imagine if you see that again and again and again with the work that you're doing, that, you'd kind of want to shake some cages and rattle some chains about moving this forward and actually having this as a potential treatment for people, especially those who are treatment resistant, Yeah. I mean, boy, could we change some lives.
People do want to be good people, with a good life. They want to contribute to their families. They want to do good for the world, you know, but they can't. Um, and what if we had the tool that we could, but we just weren't giving it to them? Mm.
Mm. Yeah, that's huge, isn't it?
Yep.
Oh, wow. Okay. That's amazing. Thank you.
That's all right.
That's a great note to
Like,
finish on, I think.
yeah.
I often see Auckland University asking for volunteers for studies on LSD and that, and I'm like, man, you guys must be inundated with people that like, I'll take LSD, I'll take LSD. I always have a little giggle to myself and I always share them on my Instagram or Facebook post, but I'm like, I'm get in quick because I
Yeah.
can imagine that you guys get overwhelmed.
We do. We get a lot of emails, but at the same time, we're always in need of more people. The really unfortunate thing as a scientist is that we do have goals to determine the mechanism by which these drugs work. And that means that actually a lot of people I have to say, a lot of people who are screaming out for these medicines who need them, they're not eligible for the research
I know.
because
So
they have too much
frustrating,
other
isn't it?
stuff going on, or it's not a good time for them to be participating in a study where they're taking an experimental medicine. And we have to be the gatekeepers of that. And it means that, actually, honestly, for every 10 emails, 20 emails, I'm probably out of touch. It might be more than that now. We might only get one person in the study.
Who fits the
So keep
criteria?
them
Yeah.
coming.
Yeah.
And
Great. Good. That's good message.
we do feel it when we can't let everybody in the study, but we're up against the regulators, we're up against people that set some very strict rules, and we'll do the best we can.
Fantastic. How can people support your work? Obviously, apart from volunteering, to be participants, is there any way that people can support your work?
The average person, by talking about our work, with their networks, with their people, about the good stuff that we're doing, and that we're good people doing good stuff. And if people want to take part, because yes, we are simultaneously inundated with emails, but often lacking in the precise participant that we're looking for at the time. So yeah, just share the word. And then I have to say as well, at the moment, because we're trying to get a women's health study off the ground at the moment, the premenstrual dysphoric disorder study, and we are struggling with the usual issues that women's health often struggles with, is that we get overlooked in funding. And so if somebody knows of pathways to women's health funding, then please do get in touch, because we're so desperate to get the study off the ground. I'm so excited by the potential. But just for the average person, just talking about us, that's fine too. That's
great.
Yeah.
And I was just thinking, for the PMDD study, do people have to have a confirmed diagnosis before they enter the study, or is that something that they'll be assessed as a potential participant?
So when the study does get off the ground, it'll be assessed, because there are so many people out there who will have PMDD that don't know. Because that was
my thought.
Yep. It is not diagnosed routinely in clinic. Apparently it takes 12 years on average to get a diagnosis. And so we want to get those people who are in year 1, 2 to 12 of their journey. We are actually also really mindful of how impactful bad PMS can be. So it's quite hard to get a precise PMDD diagnosis, but you might still have debilitating symptoms. And so the study is actually also going to include people who are maybe sub-PMDD, but still debilitated by the mood effects of their PMS. So yes, no, we will have the people on board who are able to provide a diagnosis.
Great. That sounds absolutely fantastic. I know that they've done some studies on PMS, I think it was, in nutrition and multivitamins, and that was a pretty good response to that as well. So I think there's so many women out there that could be helped by having research, and actually then the research being shared with the medical people who are providing the possible solutions, which is the next step, isn't it? Like, even if we find the solutions, it's then like, okay, so how do we actually implement these in real life? And especially with psychedelics, it's going to be a bit of a long journey.
Absolutely. I do think that too, is like just even receiving a PMDD diagnosis, let alone a treatment, is a barrier in New Zealand. But that's where I come back to, what can the average person do? Just talk. If we just talk and talk and talk about how important this research is, how legitimate these disorders are, how people are being affected, then we can start the conversations, because people know doctors and people know other academics and they know other health professionals, or they know people who are affected but have no idea they're affected because for some reason they think their experience is just normal, often because they've been told that. If we just talk, we can change the narrative, and maybe when the evidence comes through, if it comes through, we'll be ready to make the change.
Yeah, be amazing. Thank you so much, Rachael, and thank you for all your work in this area. I love it, and I keep a close eye on your research and what comes out from the University of Auckland. And it's been so good to hear the research that you're doing, the work that you're doing, and the results that you're seeing. It's fantastic.
It's been so good to see you again. I love that we're both still meandering about in this space, trying to do good. So no, thank you for having me. Thank you for giving me this opportunity.
My pleasure. Any last words?
Well, no, I think I've said all the things.
Great. Fantastic. Wonderful. Thank you so much.
Thank you.
See you.